Top Med Talk.
Welcome to the Roundtable on Top Med Talk. We are in the 6th Annual Congress for Enhanced Recovery and Perioperative Medicine, hosted by the American Society for Enhanced Recovery and EBPOM International, Evidence-Based Perioperative Medicine. My name is Desiree Chappell, host of the Roundtable, and we are joined today by Dr. Philip Corvo. He is the chairman of surgery at St. Mary's in Waterbury, Connecticut. And we also have Vicki Morton. She's the director of Enhanced Recovery at Providence Anesthesia in Charlotte. Guys, thank you so much for joining us today.
You're welcome.
We've had some great discussions here at ACER over the last day and a half, and obviously a lot of discussion around enhanced recovery. We've been talking about enhanced recovery for kind of non-cardiac patients, non-critical patients. There hasn't been a lot of discussion about critical care patients and the critically ill. So I was wondering, there's been some other discussions about doing some pretty big surgeries and complicated procedures. And so is enhanced recovery something that we can use for that type of patient? Or should we be doing it for everybody's healthy, kind of the perfect patient? What is your experience with taking care of these types of patients?
Sure. Well,
Vicki?
I think that the critically ill patient is still the ideal patient. They will greatly benefit from the elements of enhanced recovery. We may not be able to do every single one of them. We may not be getting them out of bed the day of surgery and walking them. We may be able to do that also. However, we just have to approach it in a little bit of a different manner than the normal healthy patient coming in for an elective surgery.
Yeah. Dr. Corvo, what is your experience with this?
I agree completely, and I think some of the history is interesting here. Enhanced recovery really started out as enhanced recovery after surgery. And for literally over a decade now, that's the way people thought of it, and it's only until recently where people made the jump of enhancing the recovery of people who are sick but didn't have surgery in the first place. So somebody that comes into the intensive care unit, the principles of enhanced recovery are the same. Allow their body to compensate the way it has been designed to over millennia, and don't interfere with that, but figure out a way to enhance it. So yes, get them out of bed as soon as you practically can. Don't give them all the fluids that we used to give them before. We would turn people into, we would joke that we were making them the Michelin Man. And that's just wrong.
Yeah.
Keep things within a tight physiologic range that we were built to live in, no matter how sick they are, and they do better.
Yeah, absolutely. So this morning we've had a great discussion about blood pressure and management of the surgical patient. And there was also some discussion from the crowd. We were talking about technology and how do we utilize technology. What are your feelings on monitoring, continuous monitoring, using technology, and does it have a place in enhanced recovery, I guess is a better question.
I think that intraoperatively, let me start there. Elements like goal-directed fluid therapy are of great benefit intra-op for the majority of surgeries. Post-operatively, I think that for select surgeries, the larger surgeries, I think it's perfectly appropriate, especially if they're going to the ICU after surgery. I do wonder if the surgeries that are going out to the floors, not as critically ill, if monitoring these patients potentially just may not work in those areas. But if they're going to the ICU and there is that level of care, that we should be monitoring them. We do a great job intra-op of really keeping things tightly controlled, and then afterwards they go maybe to the ICU and nothing is followed and it's undone somewhat.
Yeah. We had that discussion this morning. Dr. Corvo, what is your experience in that?
I agree, and I like the way you said undone. I think what happens now is we think we're monitoring people appropriately, but we're probably doing it wrong sometimes. Constant discussion in the ICU as well. They have a blood pressure cuff on. I don't like the number the cuff is giving me, so I'm going to pay attention to the A-line because it's more expensive. Okay, but the A-line tracing's like completely flat, so why are you paying attention to it?
Yeah.
And the reality is, no matter how good your blood pressure cuff or your A-line is, you're measuring the pressure in somebody's arm, and we want to know their pressure in their kidneys and their liver. Yep. So you need something better. I grew up in the time of swans. I really miss using a swan. I do think they were mischaracterized. But if you have the ability, and we do, to see people's intravascular fluid status and, again, keep them in that physiologic range where they're happy, that's what we need to do.
I completely agree. And we all know, even if we are getting a blood pressure, a blood pressure decline is our late indicator, right? So
Right.
we already are behind the 8 ball if we see hypotension. So we need to use parameters that are a little bit more dynamic and give us more of a real-time picture.
Yeah, for sure. And I mean, there's a lot of technology that's coming out there that's, a lot less invasive than a swan that can give us that. And, one piece when you add that technology into practice, I just think the learning curve is so steep on it and people get so frustrated. One thing I think anytime we're talking about monitoring with or without newer technology is that what are people actually doing with the information that these monitors are collecting? What are your parameters? Do you have a protocol to follow? Is that something that you guys use, Dr. Corvo, in your practice? Do you have specific parameters and protocols that set up the expectation for if I'm having blood pressure issues, this is what I do? I don't just automatically open the rollerball clamp and give them fluids, or
Right.
you know what I mean?
Yes. We absolutely do have flow charts for exactly that. And if this is the blood pressure and you don't like it, do these steps first. If they work, great. If they don't, then go into this pathway. I think the biggest challenge that we have is when somebody comes from anywhere else in the hospital into the intensive care unit, the initial frenzy sets people up in a certain direction, and it's only after we've put 3 vasopressors on somebody that we whip out the monitor that we should have brought out, literally 2 days ago.
Yeah.
So that's the challenge that we have.
Yeah, for sure. Vicki, what is your experience? I know that you've done a lot of teaching and educating nurses for post-op care, and I'm not just talking for critically ill patients. I'm just in general. What is your teaching? What are the teaching points?
I first start by teaching them the literature. I pull out the literature and say, this is what the evidence is telling us is the right thing to do. So this is not just me coming into the unit asking you to provide more care and to keep you busier. There's a method behind the madness. So needing them to understand that literature and the evidence. And beyond that, giving them a protocol to follow, but also being available, because you introduce something like this that's new to them. Not all critical care nurses are used to dealing with things like stroke volume and cardiac index, perhaps in the CCU or the CVICU, but not necessarily in a medical surgical ICU. So making sure that they understand what it is that they're treating, why they're treating it, giving them a very defined protocol, what fluids, when they should document, what we're looking at, holding them accountable, and always being available.
Yeah, for sure. So how, Dr. Corvo, you said you do have some protocols and pathways in place. What are you doing to monitor that people are actually utilizing that? Or are you doing like process measures, or are you able to pull data to kind of see that?
We're able to pull the data. The trick sometimes is actually getting people to enter the data in the first place, because they're busy taking care of the patient. So the more automated the data collection is with whatever monitor device we're using, the better. And now a lot of them just plug right into the monitors that we have in the bed. If you have the right, I'm going to say software plugins, you can even have it automatically upload its information every 10 minutes or so right into your EMR, which is great. And once it's in the EMR, you can do anything you want with it.
Yeah. One point when we talk about teaching the nurses, and one of the other guests we've had on the podcast, they were talking about providing post data about a case that went really, really well, and they were on this ERAS pathway and they had this great outcome, and they could look at all pieces of the chart, everywhere there was, they followed every piece of the pathway and every piece of the protocol. And then versus when the patient, and I hate using this phrase, but people understand it, falling off the pathway, right?
Yep.
So they didn't fulfill the intended outcome, and putting those two next to one another. And I've done that in my own practice intraoperative, like, okay, this patient came out with, pretty severe post-op hypotension, post-op day 1 and 2. We're still really struggling to catch up with that. What did our intra-op piece look like? And is that something that you've utilized in your practice, Vicki?
Yeah, absolutely. Constant feedback is so important within an enhanced recovery pathway, not just to help clinicians understand what's going well and maybe what's not going so well, but to make sure that they know the data. They know how they're contributing to this. I think it's really important to go through those steps, albeit it may not be so comfortable sometimes, because maybe clinicians feel like you're saying it was their fault. It's not punitive. It's a learning opportunity. And I try to remind them of that. But I think it is very important to not just look at what's so great here, but what are we not doing so great and what do we need to fix?
Yeah, we learning from our experiences, right?
Yes. You can imagine a lot of these cases end up getting presented like at M&M conferences. And I think you tend to learn a lot more from the things that didn't go as well as they should have. So you come to a conference like this and people give you their case studies and you're like, wow, that was fantastic. The reality is they did it 50 other times and it wasn't so fantastic, and they're showing off when they give you their case study.
Yeah, absolutely.
But when you point out to your staff, here's where we went wrong,
Yeah.
here's what we should have done instead, now you've helped the next patient.
Yeah, absolutely. I would love for you to be able to come back, and there are plenty of other topics that we can discuss, I'm sure, all day long. But I appreciate you sitting down with us. I think it's been a great conversation. Please join us for the rest of ACER 2018. We'll be coming to you with other roundtable discussions. Thanks so much, you guys.
Thank you. Thanks for having us.
Top Med Talk. And don't forget to follow Top Med Talk on LinkedIn, Facebook, and Twitter.